Hello, IT team, can you hear me? Ask the IT team.
Yes, ma'am. Anuj this side.
Can you enable the share option for Madam Nidhi Gupta, please? She is the
Okay, ma'am.
first
Okay.
resource person queue, so please enable screen share option.
Yes, ma'am. Done. Done, ma'am.
Nidhi, is it okay?
Yes, Ava, perfect. Thank you.
Yeah, just a couple of minutes. We are just starting. Just give me a couple of
No
minutes. Okay?
problem.
Yeah.
Take your time.
It's been non-stop since 10 o'clock. We have been running into various sessions in and out since morning.
But I
Yeah,
think that's
so
really good. You took this initiative.
yes, I mean about 60 odd speakers and 3 days.
I know, big task.
So yeah,
Nonetheless, you
big
would have
task,
done
but
really
less taxing than a live physical
live.
conference. I mean, virtual it is still okay, you know. I mean, but
Mhm.
you miss the warmth of meeting people.
Meeting people, yes. Indeed.
So we have Dr. Rajan Ratnam also from UNSCAP. Sir, welcome. Can you hear us?
Yes, good afternoon and thank you very much.
Okay, sir. So you are joining us from Thailand or from India
No,
office?
no,
Where are
no.
you?
We have a Delhi office from New
Oh,
Delhi.
you're in Delhi office. Okay.
Yes.
Okay. Great. Great. Because I was getting confused with yours. I think you're based out of Thailand also, was it?
No, our head office is in Thailand.
Yes, sir. That I know. Yeah. Yes. Yeah. Okay. So you are based in India office.
We are in India, which is a South Asia office.
Yeah, I know. I have come there in Kutub institutional area. You are actually neighbors with Ford School of Management, sir.
I know, yes.
Okay. So now we are going to have Dr. Prasoon Chatterjee from All India Medical Institute, and just waiting because there is a 8.5 hours, time gap between New Zealand and India. So I think Professor Vanessa is also going to join in a couple of minutes. So is it all right if we just take a couple of minutes more? Is it all right?
Yeah, sure, fine.
Yeah, just a couple of minutes. Yeah, sure. IT team, can you please enable the sharing option for me as well? I to start with a brief video and then we'll go on further.
Okay, ma'am.
Okay.
Okay, ma'am.
Thank you. Okay. About 3 minutes odd small video on our 20 years journey. Little difficult to encapsulate for the people who have joined in. This is for a very, very brief introduction about our work on geriatric care and other areas that Anugrah has undertaken. Just about 4 minutes video. So welcome back, all the friends, and I'm glad to see all the resource persons have joined in. And just to give a brief, introduction about Anukray, I played that video, and it's a pleasure having all of you. And if I can request you all to please switch on your videos, so it'll give a nice feel to see Shalini is back.
Yeah, good
Great.
afternoon, everyone.
Yes. Shalini, let me share something informal with you. That this panel actually kind of constitutes of three. Now, there are other two friends as well, but at least two of my very, very close friends who are known gerontologists, and we have been known each other for a very long time. Professor Vanessa has joined from New Zealand. Welcome, Vanessa. Can you hear us? I think she is unmuted, but I think she's still getting connected. So, and we have Dr. Nidhi Gupta. She was earlier with Tata Institute, and now she is with John Hopkins. And we have Dr. Rajan Ratna, and very welcome to Dr. Prasoon Chatterjee.
नमस्ते
नमस्ते। और आपके बारे में हमने बहुत बहुत कुछ अच्छा डॉक्टर वीरेंद्र मिश्रा से सुना था NISD में। उन्होंने कहा कि मैं आपको इनवाइट करता हूं, पर हमने वो जिम्मेदारी शालिनी जी को दी कि शालिनी जी आपको इनवाइट करें, जबकि ये कार्यक्रम NISD द्वारा स्पॉन्सर्ड है, मिनिस्ट्री ऑफ सोशल जस्टिस द्वारा। So आप सभी all resource persons most welcome, and we have in this panel we have a lot of management students, and we have lots of old age homes and NGOs who have joined in. So all speakers are welcome to actually speak in English, but little bit somewhere Hindi if you want to use, you are most welcome to do that also. And in backdrop of COVID pandemic, this session has assumed more significance. And the title of this panel today is How to Enable Sustainable Ecosystems, with special emphasis on income and health security of senior citizens. These two things have taken a huge hit during this pandemic. In this previous session, we were discussing actually about the elder abuse and age-friendly habitats, and also the legal provisions in the earlier session actually. So there were a lot of queries from students, from family people, even from senior citizens on how to cope from, I will not say post-pandemic, because it is still there, very much there, raging, at least in Maharashtra, Nidhi, from where you have come in Mumbai, the figures are climbing up steadily. So response mechanisms, A, of senior citizens, B, of course, how family has to respond to them. And we are also, I want to share with you that under the Social Justice Ministry, we are hand-holding and we are supervising around 50 old age homes across North India. So the challenge was also how to keep senior citizens safe in old age homes. Locking them up like jail inmates is not the solution, because it takes a toll on their mental health. So today we have a very, very distinguished panel. Remarks will be given by Dr. Nidhi Gupta. She is a senior researcher, Uttar Pradesh Health System Strengthening Project, Department of International Health, John Hopkins University, USA. And then I'll have Professor Vanessa Baholt. She is Professor of Gerontology, School of Nursing, School of Population Health, Faculty of Medical and Health Sciences, University of Auckland. She is joining us. She has joined us from New Zealand. And then we'll have Dr. Prasoon Chatterjee, Associate Professor and a known geriatrician from All India Medical Institute. And then finally, we'll have Dr. Rajan Ratna. He's the Economic Affairs Officer from UNSCAP, Delhi. So Nidhi, over to you. We start with you with your introductory remarks. Thank you.
Thanks, Dr. Abha, for getting us started on this important session. Before I begin, I would like to thank the organizers for which is the NIST, the Center for Social Development, Regional Resource and Training Center, Anugraha, being the main organizer, as well as the UN Information Center for India and Bhutan for organizing this national webinar series on the importance of developing a sustainable ecosystem for older persons. I would also like to congratulate the organizers for this progressive thinking and timeliness of this event and encouraging participation from diverse stakeholders. This is indeed a big step towards increasing the awareness as well as sensitizing these diverse stakeholders on population aging and ways to address it, especially in the epidemic and the pandemic that we have been facing. So as I have been tasked at providing introductory remarks for this plenary, what I would do is I would try to lay a foundation for discussions to give a good understanding of the context of population aging in India, and then which would help in further discussions and deliberations by the panelists. So I would be sharing my screen now.
Kamalji, please leave screen share. Yeah, thank you. Thank you, Kamalji. Yes, Dr. Adi, you are good to go. Thank you.
So is it visible in full screen mode?
Yes, yes.
Okay, great. So what I've done is I've tried to organize my presentation in a way where I would talk about the context of population aging in general and India in particular. And then I would try to establish the need to focus on income security and health security for older persons in India. And I would then give a glimpse of the different policy and program interventions in India for older persons to promote income security and health security. And towards the end, I would then be talking about a very macro level view of the challenges and the opportunities that exist in addressing the aging issues. So, as we all know that the world is aging rapidly, and when we say that the world is aging rapidly, to get a understanding of these numbers, we would be having about 2 billion older persons by the end of 2050, and in general, it is going to be, we are going to double the total number of older persons in the next 35 years. But what is most astonishing is that around 80% of these total older persons are going to be living in developing countries like India. I have an illustration here which clearly shows that population aging is happening rapidly across all the regions of the world. However, if we look specifically in Asia and Latin America, these figures are jumping from 9% of total population to 24% of the total population by 2050, which is alarming. So the developing countries have less than 35 years, less than 30 years now to actually strengthen their social and healthcare systems to address the rapidly emerging needs of elderly. To dig a little deeper in what is the situation in India, this graph depicts the three population groups. In the red line, if you follow the red line, it indicates the 60+ cohort. And the green line indicates the percentage of children in India's population over from 1950 to the end of this century. So what is most glaring here is that the intersect when the older persons would exceed the number of children in our total population, which is going to happen by 2050. So we will have more older persons than children in our total population. And what is even more glaring is that the total population of older persons would triple by 2050 from 2015. So within these 35 years, the population is going to triple. So in 2015, there were about 116 million older persons in our country, which would increase to over 300 million. And to imagine what 300 million would be like, you can imagine the total population of United States of America currently. So we are going to have that many number of older persons in our country, and by the end of this century, it is projected that we would have almost every third person would be 60 plus in our country. So this is alarming. Hence, there is a need to talk about population aging, bring it on the developmental agenda, and try to get attention of political leaders to address these aging issues. The third line that you see in blue indicates the 80 plus population, which is gradually increasing till 2030, and then suddenly there is a steep increase in the proportion of oldest old, and oldest old are defined as 80 plus in our population. So that is another unique distinctive feature of the population changes that are happening in our country over a period of time. When we talk about India, there is a lot of heterogeneity, and it would be incomplete if we do not speak about the regional distribution of older persons in our country. So if you look at this map, very clearly the southern states of our country and a couple of northern states which are depicted in red are the ones which are demographically more advanced. Demographically more advanced means they have greater proportion of older persons in their total population as compared to the rest of the country. However, if you look at the central part of the country, which has states like Uttar Pradesh, Bihar, Madhya Pradesh, etc., these are the states where the population density is higher. And because these states have higher population density, in the times to come, majority of the older persons in our country are going to be residing in the central part of the country. Hence, it is important to also acknowledge the regional distribution of older persons in our country when we understand aging population. This table is to give a glimpse of the socio-demographic profile of the older persons in a country. And some of the indicators have been highlighted in red to draw your attention, especially as you can see, like most other countries, India has more older women in the total elderly population. And if we look at 80 plus population, it is the decadal growth rate of 80 plus population is the highest among different population groups. And while the total older population is going to triple by 2050, the oldest old population is going to increase by 4 times in the total population of our country. Some other aspects that I would like to highlight here include that majority of older persons live in rural areas in the country, which is to the extent of 71% of the total older population. If we look at literacy rate, which is very important to understand in order to develop interventions which could easily reach the beneficiaries for whom they are targeted. It is important to understand the level of literacy, to understand the modes of awareness campaigns or sensitization that should be conducted. So especially older women, the literacy rate is really very low for older women. Another aspect is their participation in economic activity, and more than half of the older persons are not engaged in any economic activity. Though it looks fine for an older person not to engage in an economic activity, however, given that majority of our country's population is engaged in unorganized sector, it becomes important to have some source of income, and if they're not actively engaged in any economic activity, their access to resources becomes difficult. And the last indicator that I would like to draw your attention to is about the marital status. And very clearly, if we look at older women, almost half of the older women are widowed, which has a lot of policy and programmatic implications, as we will see in further slides. Hence, to look at the characteristics of population aging in India, we can say that one of the important features is feminization of aging, ruralization of older persons, and the rapidly increasing old in a population, which are important features that need to be kept in mind while understanding the aging issues or designing any kind of interventions. In addition to the various factors, various profiles that we had seen, I would also like to draw your attention to the living arrangements and the family relations of older persons, which are continuously changing and are very dynamic now. As you would all agree that till now, the institution of family was thought of as the primary caregiver for older persons, especially in Southeast Asian countries, developing countries like India. However, the data clearly reflects that this is changing very rapidly, and we see that greater and greater proportion of older persons are living either alone or with spouse only. That means they're living in absence of other family members who could have been their caregivers, and that was thought of that they would be the primary caregivers. In addition to that, if we look at the gender-wise disaggregation, we find that the greater proportion of older women are living alone. One of the reasons is that more older women are widowed, as we already saw. And another feature to highlight here is that when we say that older women, greater proportion of older women are living alone, then it is the case both in urban as well as rural areas, which may be thought that, you know, in rural areas there is extended family, but the data says otherwise, that this phenomena of older women living alone is increasing both in urban as well as rural areas. After looking at the social aspects, I would briefly talk about the epidemiological transition, that is the health and the diseases of older persons. And we clearly see, like most developing countries, India is also having the double burden of diseases, and older persons get affected with both. So the burden of communicable diseases continues to increase, and there is increase in the incidence and prevalence of non-communicable diseases, which is clearly illustrated by the study, which is the Building Knowledge Base on Population Aging in India, conducted by UNFPA in collaboration with various academic institutions. We all have seen that older persons are more vulnerable to epidemics, and COVID has taught us that in every dimension. We have heard that older persons are more vulnerable to epidemics, and they are most impacted by the epidemic in terms of social isolation and the mental health that has been affected. So I thought of also highlighting what are the factors that increase the vulnerability of older persons to these respiratory epidemics. So this paper highlighted various factors that determine the vulnerability, that talk about why older people are more vulnerable, which include behavioral factors like the health-seeking behavior of older persons, demographic factors like the increasing number of older persons in our population, and the increasing age of older persons. It also talks about the biological factors like immunosenescence, existence of comorbidities, which makes them more vulnerable to these epidemics. Some of the social factors highlighted by that paper include the type of home in which they are living, the extent of social isolation, assisted living, etc. And last but not the least, the availability and access to healthcare is another important factor that increases the vulnerability of older persons to these kinds of epidemics. I also tried to study the physical mobility of older persons, because physical mobility is reflective of health of a person at one end, and also it is one of the factors that enables social connectedness. Hence, this is from the analysis from National Sample Survey 2014, which clearly shows that as the age increases, the social connectedness decreases, because the physical mobility is decreasing, especially among 80 plus. If you see the alarming figures of 20% of 80 plus are confined to home, and another 7% are confined only to their bed, which means that approximately 3 million of the oldest old currently have varied levels of long-term care needs, which include both social and medical care needs. Another important dimension that increases the vulnerability of older persons in developed countries as well as developing countries is dementia. And according to the National Dementia Report of India, by 2050, it is projected that there would be over 14 million people living with dementia, which are the most conservative estimates of the number of people who would be living with dementia. And dementia has been reported as one of the main causes for disability in later life, which impairs the activities of daily living. And another important feature here is there is summarization, and according to this report, more women are likely to be in the people with dementia. Hence, another factor that needs to be kept in mind. Now that we have looked at the social aspects and some of the health aspects, I thought it is important to also reflect on the economic dependence of older persons, for which there was some data which shows another startling figures. 4 out of every 10, that means 2 out of every 5 older persons reported that they are fully dependent to meet their economic needs. And if we break it by gender, then older women, among older women, 3 out of every 5 older women are fully dependent, and another 20% are partially dependent to meet their economic needs. However, there was no difference by place of residence. That means rural versus urban, there's not much difference, but gender-wise, there is a great difference. So in the scenario where the economic dependence of older persons is so high, how do they go about bearing the health expenditure and the other expenditure? So the data reflects that according to the NSSO data, 86% of the total older population is still not covered under any of the schemes for supporting the health expenditure. Now, this data, the flag to this is that this data is from 2014, and post 2014, there have been various policy as well as programmatic initiatives, and various schemes have been started to provide health insurance to older persons in specific and general population as well as people who are working in unorganized sector. So there have been various programs. However, the impact and coverage of those programs is yet to be studied. Hence, this clearly takes us to the next level, that there is a need for a sustainable ecosystem for older persons. By keeping these things in mind, and to what I could think of is that we need to focus on 3 major pillars for sustainable development, which are health security, social security, and age-friendly environments. If we work on these 3, in strengthening of these 3, we could bring about a sustainable, we could develop a sustainable ecosystem for older persons. So now I would like to give you a glimpse of major policies for health security that are there in our country, which clearly indicates that the aging issues have drawn government's attention, and they have in some way acknowledged the need to address the health needs of older persons in specific. And some of the programs, if you see, are also related to various diseases that older persons encounter more often. So these are some of the policies and programs and some of the schemes, which Rashtriya Vayoshri Yojana is one of the most recent schemes that has been launched by the Government of India to provide physical aids and assisted living devices to older persons who belong to the below poverty line. In addition, in order to encourage people in general to include physical activities and sports in their everyday life, the Government of India has launched the Fit India movement very recently, just a couple of years back, and which is a very progressive move by the Government of India in order to improve the health of people. These are some of the examples of the social security schemes and programs that we have, which clearly indicate that not just the income security, but food security and, providing pensions for unorganized sectors. These are some of the things that were earlier not non-existent, have drawn policy and programmatic interventions, and the impact of these is yet to be seen. So it takes us to what are the challenges and opportunities that we need to address. So clearly, though there is an improvement in the political will that we see, however, it is not sufficient to increase the needs, to address the needs of the rapidly increasing aging population that we have. There is a need for efficient implementation of the existing schemes, both from the system's perspective as well as the beneficiary perspective. And there is underutilization of the allocated budgets, which is a gross problem across majority of the programs that are existing, hence that needs to be addressed. And the most important is the heterogeneity among the older population, which requires the need to innovate different models to address different kinds of needs that are there. Nonetheless, the way to go ahead is to promote intersectoral coordination, because aging issues are diverse and require interventions which are multidisciplinary. Strengthen research to enable evidence-based decision-making. Build capacity of the human resource to address the training and the training of the manpower to address the aging issues. And last but not the least, given that the institution of family is withering away, we need to strengthen the health and social systems at the community level, which is very important for developing a sustainable ecosystem for older persons. With this, I would like to conclude, and I hope that this lays a foundation for deliberations by the speakers in the plenary. Thank you.
Thank you, Dr. Nidhi. Exhaustive, excellent presentation, I should say. Am I audible?
Yes, I can hear you.
Okay, I think there was some echoing sound, so I don't know what's wrong. Yeah, I think you'll need to close this from the top, this presentation.
Sure.
There's some echoing sound happening.
I think I'll put myself on mute. That might help.
Maybe, I don't know. Yeah. I can't call it a preliminary. I can't call it basic. I can't call it advanced. This was just the perfect start, I should say. And very succinctly put, you've given us a very, all the students who are absolutely, I would say, new to the basics of gerontology, you have laid a very, very informative and very good base to start with. What do you say, Dr. Shalini? Wasn't it completely,
Yes,
engrossing?
yes, absolutely. Even, when Dr. Nidhi talked about Fit India movement because that's what I teach within my CSR course also. When we try to analyze the various initiatives the current government has launched since 2014-15. So I could relate it very clearly, even very beautifully she has explained, right? In context of what is the current scenario and what are the issues the senior citizens are facing. And especially during pandemic, that was great because we all know, we all have faced, even our parents, our grandparents
Yeah.
have faced. So we can relate very closely. So really, it was a good kickstart for our this
Yes.
panel.
Yes,
Over to
and
you,
also
Dr.
what
Abha.
you showed, Nidhi, the numbers. I mean, rural women, rural elderly, and especially women, the dependence figures are very alarming. And I think government needs to wake up with some kind of direct intervention systems for the rural elderly now. That is important. We discussed it in
That's
the
true.
morning also, but that is actually, and the director NISV did respond to that because there are coming up with new schemes like self-help groups in village areas, Social Abhiyan, which they are going to launch, I think, very shortly, like nutrition support for senior citizens. But I think much more ago, when I did my PhD in rural aging, I could see the gray tsunami like coming in. But now, 2 decades hence, problems are more acute and responses are still less, And the person who guided me in this field and the person who accompanied me to my Himalayan areas and rural areas is none other than Professor Vanessa Berholt, whom I know for last 20 years. When I gave my first presentation in West Virginia in Rural Aging Conference in year 2000, she was there. And she has been a part of all subsequent international conferences where we met. So good to see you, Vanessa. Welcome.
Thank you so much, Arba, for inviting me to be part of this panel. I'm delighted to be here.
Yes, so virtually, but at least we met after several years. So thanks to the technology and thanks to Ford School of Management, and we could connect back.
So true. A warm welcome on our behalf also. So over to you, Dr. Vanessa.
I'm
Yes,
a professor of
I would like briefly introduce Vanessa, and then she can go ahead with her presentation. So for benefit of more than 200 now closely students, NGO partners, personnel, academic faculty, from all different sectors of life. We have around close to 300 persons who are gradually joining in. So just to introduce Professor Vanessa, she has worked as a researcher at Bangor University in UK. While she undertook her PhD, she has been the director for the Center for Social Policy Research and Development at Bangor University. And subsequently at Swansea University, she has also worked as Director for Center for Innovative Aging. In 2016, she was appointed as Director of Pan Wales Center for Aging and Dementia Research. In 2019, which I keep seeing her photos on Facebook, she has moved to New Zealand to take up an exciting new position as Professor in Gerontology in the Faculty of Medical and Health Sciences. And she jointly in the School of Nursing and School of Population Health. And lots of papers, lots of publications. She's a pioneer and my mentor and my guide as well. So thank you so much, Vanessa, for being here today.
Thank you, Alva, so much for inviting me. And it is lovely to see you, even if it is via virtual space. It's fantastic to see you again. We have had some amazing times out in rural areas of India before. I'm going to take a slightly different take on my presentation today, slightly different from Dr. Gupta's.
Yeah.
I'm just going to share my screen now.
Yeah.
Okay, is that okay? Can everyone see that?
Yes, we can. Yes.
Fantastic. Okay, so today I'm going to look at social protection and Indian culture within a sustainable livelihood framework. So within this framework, policies, legislations, institutions, conventions and culture, such as norms and values and beliefs, are considered transforming processes. And together they constitute a complex system that's part of the cultural political economy. And they govern access to assets and power. And so the impact on the livelihoods of older people. From this perspective, then, cultural political economy determines the extent to which a person has choices, has to make choices, or has no choices over the care they receive in later life. And in this particular presentation, I'm going to consider relocation to old age homes as one very specific outcome that's determined by this interrelationship between livelihood assets and the transformational role of social protection and culture. Using framework analysis of qualitative data from interviews with 30 residents of care homes in Tamil Nadu, I'm posing two overarching research questions, which are designed to interrogate the functioning of the social welfare system in India alongside the beliefs and values that legitimize it. The first question is, how did social protection aggravate or mitigate livelihood shocks and influence relocation to old age homes pre-COVID-19 pandemic? And the second is, what are the implications of these findings in light of the COVID-19 pandemic? So first then, thinking about social protection comprises the public and private policies and programmes undertaken by societies in response to various contingencies to offset the absence or substantial reduction of income from work, which is clearly something that happens to a lot of older people. Within a sustainable livelihood framework, these comprise the capabilities or assets and activities required for a means of living. And social protection has this potential to be a transforming structure that ensures sustainability of livelihoods. As a transforming structure, social protection could include effective preventative schemes designed to reduce vulnerability to shocks to livelihood assets, and remedial schemes to support recovery from shocks to livelihood assets, or directly provide a means of living for anyone who's unable to secure this for themselves. Social protection doesn't usually include healthcare, which is generally addressed as a separate issue. And I was glad to see that Dr. Gupta talked about some of the health programs that are available in India, because I'm not going to address that here today. The policies and programs and activities that comprise social protection are taken in response to vulnerabilities, risks, and deprivation which are deemed socially unacceptable within a particular polity or society. Where access to social protection isn't universal, as in India, social norms are used to delineate the fundamental values that comprise necessities of daily living. So, for example, the level of access to housing, food, water, and clothing, and access to family. Those people that are lacking the necessities of daily living and the financial means to purchase them are usually categorised as living in poverty. And in a means-tested system, they would be eligible to claim social assistance. So moving on to think of the context of social assistance in India. In India, social assistance for older people is mainly provided through the Integrated Programme for Senior Citizens, the IPSRC, and the National Old Age Pension Scheme. The IPSRC is intended to provide basic amenities for older people, such as food, shelter, and medical care, and is administered through grants to registered old age homes and day centres that are paid directly to the providers. On the other hand, the National Old Age Pension Scheme, the government provides payments directly to older people living in households that are registered as below the poverty line, without physical assets, so without land or property, income, or without family support. So let's consider this in a little bit more detail. Firstly, let's think about that family support. In 2007, the Maintenance and Welfare of Parents and Senior Citizens Act mandated children with sufficient resources to provide support to older people who were unable to maintain themselves. And that Act was amended in 2018, extending the network of relatives responsible for providing care to include grandchildren and other relatives. So in situations where support is not provided, older people can take relatives to a tribunal to obtain maintenance orders, and relatives who do not comply with the maintenance orders may be fined or imprisoned. As eligibility for the National Pension Scheme is primarily based on the availability of family to provide support, only a small proportion of the older population are covered by this form of government social protection. 18.6% of the population over 65 receive payments. So second, let's consider the categorisation of those living in poverty. Many of the poorest households do not have the financial means to support an older person. It's been estimated that between a half and 3/5 of the poorest households in India are not registered as BPL or below the poverty line. Older people that have families that are unregistered as BPL are often unable to claim national pension. The reliance on informal social protection based on the cultural family norms in India, coupled with this patchy coverage of BPL registration, means that it's really important for us to understand those lived realities for some older people in India, because family support might not be fulfilling all of the functions of the social protection that are assumed by the government. And relocating to old age homes may be for personal care, but they may also be due to the failure of policy and legal systems to protect older people from harm and to support the most vulnerable in society. So in order to frame up the analysis and inform our thinking today, I've drawn on the Sustainable Livelihood Framework. And in this framework, livelihoods comprise the capabilities, assets, and activities required for a means of living. And a livelihood is sustainable when it can cope with and recover from various stresses and shocks. So in this study, livelihood assets were categorized into groups comprising human assets. So these include things like skills, knowledge, health, ability to work, ability to look after oneself, and social assets, including family and friends. Natural assets include land and water. Physical assets include housing and sanitation, and financial assets include savings, credit, debt, and income from employment, trade, and remittances. All 30 of the participants we interviewed in care homes were in there because they deviated in some way from the cultural family norm. So there was something about their family that wasn't this traditional extended family providing support. And we found 4 main groups of participants, which were based on these key features. And today I'm just going to draw on just 2 cases, 2 exemplars that particularly highlight issues concerning social protection. And I've chosen these because they can really illustrate how changes to policies could benefit older people. So the first case is from group 1, which we can see here is no children. And in this case, Deepak had no children. He was married, but had no children. The second case study is from group 2, where Malia had 1 daughter and no sons. So let's move on to actually look at one of these exemplars. So Deepak at the time of interview was 68 years old, and he was widowed at the time of the interview. But previously, he had been engaged in daily wage labour in agriculture or construction since the age of 23. He was married, but his wife was unwell. As he received irregular low wages, he struggled to pay for her medicines. Deepak had a stroke when he was 50, and a year later, he was paralysed, preventing him from working or for looking after himself. And he said, for 1 year, my wife was supporting me to move around. But then my limbs became so weak that I couldn't walk anymore. Deepak's daily needs were met by his wife until her health deteriorated and they had to pay local children to fetch water, do the shopping and cleaning. With no household income, they were reliant on charitable donations from visitors and neighbours. 5 years after Deepak was incapacitated, his wife passed away in hospital. Deepak sold his house to pay for her hospital fees, and he moved into makeshift accommodation closer to his brother's house in order to receive care. He said, "I don't have a house of my own to dwell in. I don't even have a cent of land. I was just there like a street dweller. I was lying there like a dog. It was a kennel covered with a tarpaulin." Deepak's brother helped him with bathing and washed his clothes. However, as a daily wage labourer himself, he frequently had to work away from home. Under these circumstances, a young local man bought Deepak food and disposed of his faeces and urine. As incontinence confers a particular cultural stigma, his consanguinously distant kin, so his sister-in-law, his nieces and nephews, did not want to provide this sort of care. And Deepak acknowledged, "They don't want to see me lying down like this. They show me disdain. There are lots of problems taking care of a person like me." Recognising his plight, the owner of the village pharmacy suggested that Deepak should move into an old age home. The old age home sector provides succour for older people without alternative sources of financial or social support. And in 2018 to 19, the government of India funded 51 institutions across Tamil Nadu through the IPSRC. We identified 41 old age homes in just 3 districts included in this study of Tamil Nadu, and mainly these were funded from non-governmental sources, so through private paid care or through charitable donations. Some facilities were unregistered and as such were not subject to state regulation or inspection. And this potentially left residents vulnerable to organisational exploit and abuse, as experienced in our second case, which is Malia. At the time of interview, Malia was 65 years old and she was separated, but she had spent most of her life in facilities run by one religious organisation. As a child, Malia moved to a children's home to avoid her stepmother's abusive behaviour. And she said, "I went on my own, not able to bear the tortures of my stepmother." Malia got married, but was abandoned by her husband when she was 6 months pregnant. As a lone female parent, she would have been marginalised and discriminated against within her community. And living in extreme poverty, Malia left her daughter in a children's home, moved into a women's refuge, and worked in the kitchen of the orphanage where she herself had been raised. In due course, Malia borrowed 3,000 rupees from the organisation to arrange her daughter's marriage. But in order to recover that wedding debt, the proprietors of the organisation retained her salary, which was 500 rupees per month, for more than 2 decades. At that time, then Malia required significant healthcare to treat a work-related burn that she sustained in the kitchen. Without any personal financial assets of own, the organisation paid 27,000 rupees for hospital fees. So Malia continued to work to pay off that debt. Eventually, her sight deteriorated and she was told that she needed an eye operation. She said, "They took me to the government hospital. They said that I should undergo an operation, but I didn't have any money." Unable to work to pay back another loan, Malia requested to move to an old age home, which was located actually in the same cluster of facilities that she'd spent pretty much her whole life in. She said, "I begged the doctor to leave me at the home for older women." So the cultural pressure to arrange a marriage for her daughter resulted in Malia's indebtedness to this charitable organisation. Publicly, the organisation's website notes that they make every effort to find suitable grooms for female residents and meet all of the associated costs. Instead, the modus operandi emulated a hybrid between a workhouse and a debtor's prison from which Malia was unable to escape. Now, the effectiveness of social protection relies on it reaching the poorest poor, but also its adequacies in making up for deficits in livelihood assets. Both Deepak and Malia received a state pension because their family's economic status meant that support was untenable. Malia's daughter was struggling to look after her 2 own children, and Malia said, "How can she help me? She could give me some 5 or 10 rupees. She is doing housemaid work." And Deepak's brother was a wage labourer, for whom providing care to Deepak would have entailed losing productive labour hours. However, the state pension for both of these people was not sufficient to cover accommodation, subsistence, health and care needs in the communities. Relocation to an old age home was often the only option available to older people without any other income. And in other examples that I haven't presented here today, older people with families were denied access to pensions. So these data were collected pre-COVID-19, and the pandemic itself will have been an additional shock to people's livelihoods for many older people. Pre-pandemic, specific features of the political economy failed to provide for the most vulnerable, excluding them from key resources, sufficient protection from harm, and a choice over where they lived and from whom they received support in later life. So there's a high likelihood that during the pandemic, more older people will have similarly been affected. Recovery from those shocks to livelihood assets was attenuated or strengthened depending on an individual's social, cultural, socioeconomic status, and those assets they'd accumulated or decumulated across their life course. They were also transformed by cultural norms, so discrimination, prejudice, and stigma also affected people's access to resources. So although deficits and shocks to assets could potentially be mitigated by social protection, our analysis revealed the antithesis. That is, many of these processes actually reinforced some of these structural, culturally constructed inequalities. So in conclusion, the situation for older people in India could be improved by making some changes to social protection. First, requesting or expecting family support is particularly problematic for older people with poor relatives. Presently, there's no financial support for kin carers in India, and this is especially important in those low-income families in which care provision entails the loss of revenue. Unless social protection includes provision for living wage, increases the number of poor households registered as BPL, and provides support for kin carers in low-income families, the care needs of older people may continue to be neglected in poor households. Second, the Act hasn't properly understood public morality with respect to responsibilities between relatives, especially how older people negotiate commitments from kin other than sons. So cultures include established rules defining what is morally permissible to do. Support in later life has predominantly been the responsibility of sons in India, and support from other relatives other than sons is rare and isn't part of cultural expectations. Thus, in order to receive support, older people without sons but other families have to be willing to transgress those cultural norms. Third, when families are unable or unwilling to provide care, an older person is supposed to initiate a tribunal in order to receive a maintenance order. Families that fail to comply with a maintenance order are fined or imprisoned. So this process assumes that older people, one, have knowledge of the Act, or two, are willing to criminalise relatives, potentially bringing shame on the family. And research suggests that these two assumptions are infrequently met. So the choice set that's available to older people with kin is somewhat unpalatable. They can transgress cultural norms by living with their daughters or other relatives. They can criminalise the family or endure destitution and death or become an inmate in a care home. And fourth, there was evidence of institutionalised financial abuse within the old age home. And in other examples not here presented here today of neglect, physical and psychological abuse. The regulation of old age home sector needs careful examination to ensure the safety and well-being of residents, but simultaneously not precipitating closure of those unregulated care homes, because they are essential to an already underserved population. And furthermore, the legal system appears to be inaccessible for older people who are of a low socioeconomic status. For example, it failed to protect Malia throughout her life from physical abuse, abandonment and financial abuse. The mismatch then between some of these examples of those lived experiences of older people in our study and that political rhetoric should have been a concern to the government. as this can undermine public perceptions of distributed justice and the legitimacy of government. As the proportion of older people increases, as Dr. Gupta explained earlier, shortfalls in that social protection system will necessitate a growth in the old age home sector. But additionally, we could predict that the impact of COVID-19 on a swathe of older people will also highlight the visibility of that incongruence between the political imaginary and the cultural norms, values and practice. So it might be timely for the government of India to reconsider that cultural appropriateness of the Senior Citizens Act to ensure that there's a sufficient level of resources that are distributed to meet the needs of older people. Thank you very much for taking the time to listen to me.
Okay. Yes, Vanessa. Very comprehensive, very exhaustive, really very informative information that you have researched on. And I think your long experience of working in India also gives you quite an edge, you know, the understanding, the deep understanding that you have of Indian culture, society, and you've applied here with lots of collaborative groups is very good. And what we are actually requesting, Shalini, is that if there are any questions, I think participants are, they can put it in the chat box since.
Yes. Till
yeah.
now, we won't have. I think at the end, can we take if Professor Vanessa will be here?
I think it's about 10 o'clock. So in New Zealand, so maybe she would go to bed. But
okay. Any questions? Please type in the chat box. All the participants, if there are questions for Professor Vanessa, I request if there's question for specific Professor Vanessa, please type in the chat box. Because we are very kind enough and we are so thankful to Professor Vanessa, despite of her busy schedule and despite of these different time zones, she's able to join us today. So very, very happy to see you, Professor Vanessa, virtually. And
thank you very much. It's a delight to be here. I will stay online for another 15 minutes just to see if there are questions, but then Arba is right. I will be going to bed.
I must say,
yes, I know,
research which you have discussed in between, the short stories, that was really interesting. That was really eye-opener, that how the community has actually reacted. And that was really very interesting to understand the various issues at the grassroots level. So that was really very interesting. So any questions? No questions till now in the chat box. I think
so from, I think on all our behalf, we thank Vanessa because it's a night for her and she would go to bed soon. So thank you very much. And then we move on to our next speaker, Dr. Prasoon Chatterjee from AIMS. Welcome, sir. Just to introduce you briefly, he's one of the very qualified geriatricians in elderly care medicine in Department of Geriatric Medicine, All India Medical Institute. And he has worked in landmark project on dementia intervention and LASI project. He's been a promoter of mass immunization against pneumonia and influenza in elderly. That's commendable, sir. And he has started Intergenerational Learning Center at Noida Vidyalaya, which is very good, where educated elderly are mentoring less privileged school children. This is one of the very good initiatives, sir, after your
I request other panelists to please keep your
no, it is the CSD 4. I think they have unmuted.
Yeah, I request
and he has awarded the best paper in several national conferences and international conferences. So we are very much privileged to hear you today. Welcome to the panel.
Thank you, madam, and thank you to the whole team. And initially, when I received your mail, I thought probably I'm the odd man here. It is more of because I'm more of a clinician, but of course I visit old age home and I'm connected with I will say many senior citizen, and mainly my focus is how to empower them, and which is probably the focus of the whole team and whole discussion here. I'm glad that we are discussing, and with multi stakeholders, we are discussing here with multinational expert like Professor Vanessa, and I was listening to her talk, and she has absolutely mentioned most of the things which is very pertinent at this juncture, especially after COVID-19. After COVID-19, we understood many things about our strength, our weakness, and probably policymaker has to take a call that how will we go ahead with this. If I'll be very brief. I don't have any slide. I will try to highlight some point and try to raise some question which we need to address in future years. So if I consider about what is the current situation, population aging is happening in all countries. This is no more a new fact, because this is almost last 2 decades we are only discussing population aging, population aging, population aging. But then what next? We also understood that health and social system everywhere need to respond. We have to respond accordingly, because the pace, if we consider about our preparation to take care of older people or to empower them, to support them, that pace and the pace they are increasing, because the speed of population aging, if I say, that is much different. We have to consider that. We have to accept, even if we talk a lot, but if we have to accept, cities and communities are mostly not age friendly. We have to consider that. Very unfortunate, but ageism is widespread. When I go to I speak in many forum, I go to many places. When I'll start with an example. In one IIM alumni meet, one elderly lady, she was 66, but well maintained, and she was very active. She was engaging herself meaningfully. When she was discussing with a group of people who are, I will say, 20 years junior than her, until unless she had not disclosed her age, people were comfortable. But once the group came to know that she is at least 20 years seniors than us, instead of continue the discussion further, or I will say learn something from her, the whole team shifted to other place and say, thank you madam, thanks for your suggestions and all these things. So this is so widespread. Ageism is so, despite the fact that including first person of this country or president of this country, all of them are senior citizen. 60% of the parliamentarian are senior citizen, but still we have ageism, which is highly widespread. Older people, whatever we say, but ultimately at the end of the day, we consider older people who are not in power and position as our burden, not a resource with lot of potential. So policies, governance, financing need to evolve accordingly. And as I mentioned rightly, this forum is probably creating that, sensitizing that. So we have many actionable area, but what I can, if I have to prioritize, I'll prioritize. We have to create age-friendly communities, which is absolute importance. Because if we start with the blog should be your home. You start with the attitude of the individual. You start with the attitude of the family member, that still my parents, still my grandparents can contribute something to the society, which is absolutely important. And similarly, my parents or my grandparents has to think that still they can contribute. They are not the burden. They are not meant only to stay at home and think for like when will the end come, so they can still contribute. Next point is we need we need to work a lot for our health sector. There, Government of India is working hard. I will say national program for the healthcare of the elderly, which is a very comprehensive program under Government of India, which has started 2010, and It is progressing well, but again, as I mentioned, demand versus need, if I weigh, a long way to go. National program from the government of India, it works in its main strategy is on preventive and promotive healthcare, which is again absolutely important if I consider for senior citizen, because seniors need more of promotive healthcare than, I will say, curative or palliation. We need that, but major thing should be promotive healthcare, like physical exercise, diet, stress management, de-addiction, which is again nowadays very common, prevention of fall or other geriatric syndrome, prevention of social isolation, which we have seen multiple reports has come, even I have published on that. Social isolation is a major issue, and which increases mortality by multiple times. It is worse than even obesity or coronary artery disease if I consider long-term mortality in elderly people. So national program for healthcare of elderly is focusing on that. It is also focusing on creating manpower for geriatric services, because we have acute shortage of trained manpower. I am a geriatrician, and I will say the number of geriatrician in this country, in India, is not even in 3 digits. So how can we think of catering like 13 crore or more elderly people at this juncture? So we need a lot of manpower. We need to focus on even medical rehabilitation and other intervention, which is needed, because with aging we need to advance in that direction also. But most important thing is sending the message to the right person, which is probably we need to work hard. People are working through mass media, other communication channel to reach out to elderly people to promote healthy aging. You must be aware that World Health Organization has declared this decade as decade of aging population, decade of healthy aging. So World Health Organization is planning to work in many domains, but of course the point we have to understand that we have to partner with each other. It's not a job of one person, one discipline, one ministry. It has to be a multidisciplinary, multi-stakeholder engagement to create older people's voice, their engagement, and still they have leadership qualities, still they have capacity, still they have capacity to contribute, capacity to go for sustainable development, which is of course our goal. Because of it has to be inclusive, it has to be and older people are no way behind in any case. So that is the this what I understand that some point we are missing here, that we are probably undermining their experience, knowledge, and skill they have. If you see the world study from worldwide evidence, what's evidence suggests is you think for entrepreneurial ecosystem, you go for digital platform. Now seniors are no way behind anywhere. They are equally. My father does more Facebook chat than me. He is fast type expert than me. So if you teach, they can go along. Then if I consider about unpaid care work, they are also, they are the first person. When I consider how to take care of my children, I first consider that my parents are the best person. So this is true. Like we can say that still we have joint family culture, as Professor Vanessa mentioned. It is not universally true, but still predominantly we have that culture, and still we consider our parents as the safest person to take care of our children. You think of voluntarism, social capital also. If I consider, they're the people who are still participating in most of the volunteering activity, be it community meeting, be it senior association, to push something, to advocate something to the government. Even if I consider about vote bank, they are the probably most important people whose votes counts maximum. These points we have to consider. Yes, they have challenges. The social insecurity is a problem. Like long-term care is a problem in this country. What previously Professor mentioned about old age home are in a really bad shape. I think NISD is working well for that, to give them a dignified aging and dignified death, which is I think right for everyone. It's not alone connected to, even if I don't connect with SDG, but it is a very basic right of human being, even if a dignified aging. So poverty, again, a policy issue. Ageism is an issue which we have to tackle together, where we have to take care of access to education, training, healthcare, participation, autonomy, as I already mentioned. But ageism is a fact where all of us has to work. It's not, and I believe the attitudinal change should come first from the elderly people themselves, because who will speak for you? You have to speak for you first. And another one more thing which is very important is preparation for active aging, which mostly we ignore. Till you are working, you have some position, you are getting a good salary package, and you think that you will never be old. But actually, we all of us will be old. All of us has to retire from our position. But then what next? What is your engagement ways? Engagement, purposeful engagement, meaningful engagement, which gives you happiness, which give you grace, which takes care of your functionality, needs to be stressed, needs to be practiced. And it is again a I will say life course perspective. All of us should work, even if in 40s, in 50s, you are in 30s, you should start thinking about your future aging process, because all of us are aging, and aging is a continuous process. So lastly, I would suggest that what is more important is we have to take the voices from them, and that should reach to the right person, that what they need actually. We are sitting in a room, we are writing for them. We have visited, we have done some study which is in a bits and pieces, because that is also a problem. If I consider about evidence generation, senior citizens, especially who are 80 plus, they have been mostly they have been excluded, considering their multimorbidity, their geriatric syndrome. So we need to consider that. Evidence generation is equally important. Recently, we have conducted one survey with WHO CRO. The data has not been published, so I'm unable to share with you many data. But to my surprise, even 60%, only 60% policymaker knows that there are some policy for elderly people. I'll say this is ignorance. This is nothing but ignorance. And 50% of them told, yes, there should be something to do for elderly people during this pandemic. But of course, government has taken many steps. From AIMS, we have started teleconsultation, some program, home care program, many places it has been done. Some program to alleviate the anxiety and provide psychosocial support to the elderly people who are residing in old age home. The problem is the charitable old age home run by most of the NGOs are not being counted as that. There are some people who are staying, like children drops them in the late night, पापा चलो घूमने चलते हैं बोल के कहीं पे छोड़ के वो गाड़ी लेके आ जाते हैं, जहां से मम्मी पापा वापस नहीं आ पाए. And thanks to this charitable organization, we from Healthy Aging India, I'm also associated with one NGO, Healthy Aging India, and we support 27 old age home in Delhi NCR by providing them health care. I'm sorry to say, most of the charitable old age home run by NGOs are devoid of any healthcare facility, which is so important. Health security is the first thing we have to provide to elderly people. And second, what recently Madam has mentioned, a concept which I want to prevail and also spread, share with you is, if we engage them, those who are till not so elderly, even someone who is very elderly, we have teacher who are 85 plus. If we can connect them with underprivileged children, or why underprivileged, even well privileged children also, still they can contribute a lot. We are seeing a significant changes in social cognition and emotional intelligence of school children who are connected with elderly people, who are getting their experiential knowledge in school classroom teaching. So this is a great way to engage each other and benefit each other. So that teaching learning process. So we have to work for their promotion. We have to work for their social security, which has been elaborately discussed. We have to definitely take care of healthcare, which has to be integrated. It should start from your home to primary health center, to secondary health center, to tertiary care center. And again, there should be a proper back referral system where there has to be a shared decision making, where elderly people and their family member, we have to take care of the caregiver stress also. We cannot just simply blame that your parents, so you have to take care. All of us has to. So a very important aspect is multi-stakeholders approach, where there will be an attitudinal change as well as participation, be it NGO, be it government, be it private sector, because after all of us are going to face that situation today or tomorrow. So better we prepare from now. Thank you, and thanks for giving me this opportunity.
Thank you, Dr. Chatterjee. Being in Delhi also, I'm unfortunately, I did not know about such wide-ranging undertaking. Also, not only as a part of AIMS head, but also from Healthy Aging India NGO that you just mentioned. So it will be a pleasure to work with you, and also invite you to our daycare center, which is near Karkatuma Court. It is Swabhiman Parisar, and we have 1400 senior citizens there. It's a collaborative project with Honorable High Court of Delhi.
Great.
And we have been running it for 3 years. So several leading doctors and other health professionals have been a part of our journey, and it will be a pleasure for us to have you there. Though COVID has limited the entry of senior citizens for last 1 year, but we are gradually opening up, very, very gradually and slowly. Secondly, what you mentioned about the caregivers is very, very crucial and pertinent, because so we are running out of lines and we are working across 7 states in North India. During COVID, when the sudden lockdown took place, it was very, very difficult even for, I mean, many people are not able to afford professional caregivers. So they have to rely on the maid servants who double up as a caregiver, even if an untrained caregiver. And initially, few days, even the professional paid caregivers not able to access their families, where they were going. So that was quite a crisis situation. And then so we have been thrown up with a demand that the family members should be at least trained in primary caregivers and helping an elderly with activities of daily living, like changing diapers or putting catheter, or how to pick up the person, those bedridden elderly or people with dementia. So we would definitely like to work together with you in basic training of family caregivers. We have infrastructure available. We have a huge community available. And we are a regional training center under Ministry of Social Justice, as I mentioned. So offline, we will connect surely. Thank you, Dr. Shalini, for connecting us with Dr. Chatterjee.
Thank you, Dr.
Sometimes
Abha.
it takes a longer detour to come here. We could have picked it up from here, but it takes a longer detour to reach the right destination.
No, when I was talking to Dr. Atul, we talked about. I said we would like you and Dr. Chatterjee to be with us, because yesterday Dr. Atul was among us. Even Professor Chatterjee, Dr. Murthy from Bangalore was also, Dr. Pratima Murthy, and that's how actually we connect.
Even Dr. Mishra, Viren Mishra asked about whether you have invited Dr. Chatterjee or not. We said yes, very much.
And I would like to emphasize one point which Professor Pasun, you have talked about intergenerational bonding. You will be very happy to know we are a management school. So in the management context, we do one of a flagship program which is known as Abhivadan for senior citizen. Because we have CSR and sustainability as a core course, we also sensitize our students on various dimensions of social defense issues and also CSR. So intergenerational bonding, which you have highlighted, is actually a very, very important, because we all are from different profession. So when you talked about multi-stakeholder analysis or a model, I think this is a very crucial time and apt, you can say that, a framework where we all will connect and we can sensitize, because we have future managers with us whom we are training them so that they will be going to enter into the industry. So I think if we have public policy as one stakeholder, we have at your institution, we have Anugrah, we have Ministry of Social Justice and Empowerment, we have international organization, and we have an academic institute. I think that could be a good ecosystem if we take it forward, because this is just a start. What I discussed with Dr. Ava also, we would like to continue, because even I am very happy to share here that the outcome of this whole 3 days deliberation would be an outcome of an edited book by international publisher, either by Sage or Routledge. We are in talking term with both the publishers, and will request all our speakers here to please contribute as a research paper or as a case study. Even Dr. Vanessa spoke about various caselets during her. Even Dr. Nidhi talks about a different perspective. And Dr. Chatterjee, you are already connected with a lot of action research organizations. So I think it will be a very great end of our second day, because we have still one session to go. What do you say, Dr. Ava? So I think we
absolutely.
have
Actually, I
56
was
plus
looking at the
participants
time
here.
when the next session is starting, Shalini.
Yeah, I
So
know.
what
We
I
still
will
have
do
10
is
minutes
that
to go, Dr. Ava. Don't worry,
we
we have
have
10
10
minutes
minutes
to
to
go.
go. So what I'll do, I will continue
So
with
I
this
think,
session.
yeah, no problem.
Shalini.
I think it's a pleasure to have all the speakers here.
And Dr.
we are
Ratna
very
is still there,
thankful.
has to speak. Dr. Rajan Ratna is there to speak from
Yes,
UNSC
yes, yes,
panel.
yes.